Hey, good afternoon, everyone. And I think we'll be getting started. Welcome to today's webinar from C4 Recovery Foundation. A brief introduction. My name is Andrew Kessler, and my firm, Slingshot Solutions, has been working on behavioral health issues and behavioral health policy in Washington, D.C. For the last 10 years. I myself have 20 years of public policy experience, and I've spent about 15 years in the behavioral health arena. So I've seen a lot of changes in that time, especially over the last few years. You can find me on Twitter at SlingshotDC. Feel free to live tweet. Also feel free to tweet on C4 Recovery Foundation's Twitter handle as well. And I just want to give everyone a reminder that you can ask your questions on your Q&A button at the top of your page. And I'll try and get to questions in the end. I've left what I think is a good amount of time for questions. And I just want to remind everybody that at the end of this webinar, there will be a poll, very brief, just a few questions. So if you can help us out, stay tuned for that poll at the end of the webinar. We would appreciate that. And with that, we'll begin. And first, before I begin with my content, I just want to apologize. It may be the holiday season, but it's also the cough and cold season. So as I get over my cough, it may interrupt us a few times, but I don't anticipate any big problems. So with that, away we go. Of course, this audience is probably already very much aware of the problem we have with drug overdose deaths, which have tripled between 2000 and 2015. In 2015, our best guess is a total of about 52,400 overdose deaths. And we see particular problem in rural communities and the opioid-related deaths there, not necessarily in terms of number, but in the rates of increase. Data has shown overdose deaths could exceed 64,000 in 2016, and our preliminary information puts the projections at 2017 at over 70,000. Over the last few years, we have seen Congress start to respond to what is being called the opioid epidemic. You will see through the course of this presentation that I don't necessarily think it is only an opioid epidemic, but it is an addiction epidemic as well. And we're going to talk about that a little bit as we talk about the policies that have been enacted in 2018. Continuing on overdose and continuing on that theme of it going beyond opioids, alcohol-induced deaths increased 37% between 2000 and 2015, reaching a 35-year high. And suicide deaths also increased by 28%. The reason I bring up suicide, and the reason I bring up all of these numbers, is that we are of the opinion, those of us who work in this area and those of us who release the statistics, whether they be at agencies like CDC or the National Institutes of Health, that a lot of these numbers are underreported. It is very, very difficult to get a very precise number of overdose deaths. And it's also very difficult to determine when an overdose death is unintentional, accidental, or is a suicide. Right now, statistics can only count a suicide if a note is left. We suspect that there are a very high number of suicides by overdose. So until we get a better understanding of what exactly the numbers are trying to tell us, it's very difficult to craft solutions. Before I begin with the actual policy changes that have been enacted in 2018, I just want to state very briefly that the advances we are making in Washington and around the country, in the states as well, are the result of several policy changes that have been made over the last several years. We all know about the Mental Health and Addiction Parity Act, which was passed in 2008, the Affordable Care Act in 2010, and in 2016, what is called CARA, Comprehensive Addiction and Recovery Act. So all of what we're doing kind of builds on that foundation we've been building up to over the last decade. But the advances we made this year in a standalone bill that was intended to address solely the opioid epidemic are quite impressive. And we're going to dive into that. And something I want to tell you about the way I present is that my slides don't have a ton of information. Most of the information comes from me and what I'm going to tell you. I don't want you to get lost in reading everything. So my slides are fairly sparse, and I'm going to try and narrate as we go through them. The Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment for Patients and Communities Act, or the SUPPORT Act, bill number HR6, was passed by the House and Senate this fall and signed by the President in, I believe, in late October. So it is now law. The law that was passed is close to 700 pages. Laws are not that simple to break down and analyze, especially when they're this long, because at this stage, even though the law is official, it's incomplete. Issues such as funding, issues such as grant applications, issues such as how these programs are going to work that have been newly created, they all have to play out. So that's going to be a common theme that you hear me address throughout the presentation. We're going to need to see how a lot of this plays out, and it is going to be up to a lot of the federal agencies that work on this issue, whether it be SAMHSA, Substance Abuse Mental Health Services Administration, or HRSA, Health Resource Services Administration. There's going to be a lot of back and forth between those agencies and Congress and those of you outside of Washington who are actually doing this work. So, and there's going to be opportunity for feedback from people such as yourself, professionals in this field. That's been written into the law as well. So the bulk of what we're going to be talking about on this webinar is this one bill, HR6. Other advances have been made for sure, but I get the sense in talking to people around the country, this is what people want to know about. It's got a fair amount of press coverage. I'm going to try to break down the major provisions for you as best I can. You can see that Congress bit off quite a large chunk when trying to address this issue. There's language about recovery, recovery support, peer support, a very popular topic, research, technical assistance, grant programs, recovery community organizations, and even more, workforce, prevention services, on and on and on. So when you have a 700-page bill, you manage to fit in quite a bit. And the best way to try and get you through it is with section by section. This is not necessarily in the order the bill was written, but the way I tried to break it down was in terms of what is new, what is probably of interest to this community, and what's going to have the most immediate impact. One big part of this grant was a continuation of what's called the State Targeted Response, or it's now called, the name was changed, it's now called the State Opioid Response Program. Last year, and continued this year, each state will receive a grant from the Substance Abuse Mental Health Services Administration to address the opioid epidemic. The total amount of grant money is $1.5 billion. Now, originally, when this grant program was written, back, I believe, in that's fiscal year 2017, it was originally $500 million. It's been increased to $1.5 billion. And the grants were allocated to the states based solely on population. So, taking that into account, it's no surprise, California got the most money and Wyoming got the least. That's how it worked. Some of the smaller states that have a very large problem with opioid overdose, West Virginia would be one, New Hampshire, Rhode Island, they weren't pleased with the allocation because their rates of overdose were significantly higher than the larger states. So some changes were made to the grant program, and as you can see that third bullet, the grant is now based on population, but with what I call a cherry on top. The states with the 10 highest overdose rates, so it's rate, not raw number, will receive an extra amount of funding to deal with the issue in their state. The single state agencies will then receive the grant, and they will have discretion as to how to spend it. And we've seen a variety of expenditures. For example, when California got their first chunk of money in FY17, they spent every dime they could on medication-assisted treatment. They felt that was the biggest priority for the state. They felt that was where it was best spent. That's where they spent their money. The state of Illinois, for example, decided to address 8 or 9 different topics. They addressed workforce, they addressed peers, they addressed prevention. So they spread the money around to different programs where they saw it best fit. Wherever you work, live, what have you, your state capital will decide how this money is best spent. Now, there are certain allowable uses that the federal government has said it can be allowed for, but it's a pretty wide range. So there's very little that the states will not be allowed to do with this money so long as the money is going towards some kind of programming for substance abuse prevention, treatment, or recovery. So an extension of this program was placed in the bill. What didn't get a lot of press, a lot of coverage and press and newsletters, what have you, that were working on this issue, they focused on things like opioid prescribing, medication-assisted treatment. This is an issue that didn't receive a lot of press per se, but I think is incredibly important. Those of you who work in this area know that we have a tremendous workforce shortage. We don't have enough qualified professionals in this arena to serve the population. It is plain and simple. Recruitment and retention is difficult. The average stay in the profession of a counselor is only about 3 years. Salaries are not what they commensurate with the amount of work required and the amount of experience and schooling that goes into the training to become one of these professionals. So in this bill is a loan repayment program for substance use disorder treatment workforce. The Secretary of Health and Human Services can enter into agreements with individuals to make payments in accordance on the principle of interest of any student loan. In exchange, the individuals must agree to the requirement services of the substance use disorder treatment employment, i.e. you must go to work in a setting and in an area that is recognized by the Secretary as having an impact on this issue. Excuse me. So, shortage area. The Secretary will pay back each year of obligated service to an agreement 1/6 of the principal for up to 6 years, with a maximum amount of $250,000. This is being done in an effort to grow a field of specialists in this workforce so we can adequately serve our population. This goes from entry-level peers, entry-level counselors, all the way up to addiction medicine, addiction doctors, addiction psychiatrists, whatever. So this program is seeking to basically increase the entire range of professionals. It's not just for one area of professionals. This comes in addition to last year's change that now allows master's level counselors to qualify for the National Health Service Corps, which is an entirely different loan program. So in the last 2 years, we have gotten our substance use disorder counselors eligible for 2 different loan programs, sponsored by the federal loan repayment programs, sponsored by the federal government. We cannot provide treatment without the workforce. Everyone is concentrating on their different areas, different issues. We could talk about overprescribing, and we will later. We could talk about medication-assisted treatment, we will later. But if you don't have the professionals to provide services, that's pretty much it. If you don't have teachers, schools don't open. If you don't have doctors, hospitals shut down. If you don't have trained professionals, treatment settings, they just can't do their work. So we thought this was incredibly important when working on this bill. And one other thing about shortage areas, it used to be that the only place a shortage area was defined as was a mental health service shortage area. And the only definition that was available was the number of psychiatrists per population. That is it. What we were able to do with this legislation, and when I say we, I mean everyone in this community who works on this, there's many of us, I don't do this alone. What we were able to do was we were able to define a shortage area as any place with a higher than average overdose rate. So let's say there is an area that has plenty of psychiatrists, but they're not specializing in medicine, and we see the overdose rate in that area well above the national average. That area can qualify as a shortage area, and people who work, people who are seeking to go into this loan repayment program, they can be sent to one of those areas in order to practice their trade and address the workforce shortage. Also in this bill will be a state Medicaid innovation program. Medicaid is tremendously important, as you probably know, to our treatment structure. And the Secretary of Health and Human Services will work with states on innovative strategies to help individuals who are inmates of public institutions, i.e. in the prison system, or in state psychiatric hospitals, and otherwise eligible for Medicaid assistance under Medicaid Program Title 19 of the Social Security Act. What this means in English is that 10 states are going to qualify for a pilot program by which they will receive an extra grant from the Center for Medicare and Medicaid Services to try different experimental protocols for treatment. Not every state will qualify for this. CMS will have an application period, and the states with the most innovative ideas will be chosen. I can also say, if the 10 states with the most innovative ideas are all from one region of the country, if they happen to be Maine, Vermont, New Hampshire, Massachusetts, Connecticut, Rhode Island, etc., they will not get all of those grants. They like to, CMS, whenever there's a federal grant or a federal pilot project, they like to spread it out geographically, demographically, large states, small states, West Coast, East Coast. So there's going to be a good cross section, because this is supposed to breed innovation. So the point is to get as much innovation as you can from around different parts of the country. One really large part of the bill addressed sober living and recovery housing. We all know that there have been, this has been a hot button topic. Those of you who may be in Florida or stay up with the news know that there's something called the Florida Shuffle, which would take too long to explain now, but it has to do with illegal kickbacks and fraud and patient brokering, whereby patients are treated as a commodity and make money on, not as someone who needs to be cared for and treated. So the House of Representatives really drove this bill, and they were very much interested in how to make improvements. What their first course of action will be is the Secretary, in consultation with a council made up of members of the general public and other specified government entities, are going to identify or facilitate the development of best practices for sober living environments. This may include model laws. It could implement minimum standards for operating recovery housing. We don't know where this is going to go, but what they want is a set of best practices to be led by SAMHSA, and then to be available for other for states and associations to do with as they choose. There is not going to be any federal enforcement yet. Most enforcement will take place at the state level. I know some states, Ohio, Massachusetts, Illinois, California, have already started their own state process for oversight, but Congress really wants to see a model and some kind of guiding document for these states to refer to. So when we say recovery housing, the way it's defined in the legislation, it's a shared living environment free from alcohol and illicit drug use, centered on peer support, and connection to services that promote sustained recovery from substance use disorders. There will be a $3 million appropriation for this effort. That's not a lot. I know to most of you, even to me individually, that's a lot of money. But in Washington, it's not a lot. So as I said before, this is kind of a work in progress as we go through the funding for next year's federal budget. People such as myself will be going to Congress and saying $3 million to come up with a whole new set. You know, there's going to be a lot of travel involved, site inspections, a lot of technical assistance needed, what have you. So $3 million doesn't go a very long way. And so we will be seeing if we can increase that number. Along those same lines, Congress is very interested with the detection of fraud and fraudulent recovery housing operators. So the Secretary, in consultation with the people described in the previous slide, will identify or facilitate the development of common indicators that can be used to identify fraudulent recovery housing operators. So the Attorney General will be involved in this effort, as it will be considered a violation of fair trade. We'll get to that in a minute to continue with any of these practices. So in carrying out these activities, the Secretary wants to identify or develop indicators which may include unusual billing practices, average length of stay, excessive levels of drug testing. Many of you may know that that's how there's a lot of, that's one of the favorites of the, for lack of a better term, the scam artists, billing for excessive drug testing, and unusually high levels of recidivism, which shows that dedication to recovery is really not a high priority for these entities if they are indeed engaging in fraudulent activities. So these are some of the issues that are going to be examined in trying to weed out the fraud that unfortunately exists in many aspects of substance use disorder treatment. So as I mentioned before, any violation, once these recommendations are codified and enacted, violations will be treated as a violation of the Federal Trade Commission Act, and it will be considered an unfair or deceptive act or practice. That's the reason that's important is because it brings it into, as I said, a criminal justice jurisdiction. Anyone who violates these standards once they're established is facing federal prosecution. A very popular topic in Washington concerning substance use treatment and recovery is the role of peers. We've seen several states use peers successfully, and I think many of us understand it's still a growing area. We're still trying to tinker with it and see where can peers best be used, how can their experiences be best taken advantage of, what can they be reimbursed for, how can they build, what services should Medicaid reimburse for, et cetera, et cetera. So Congress is very interested in the role of peers and the benefits they can bring to the table. So the bill that we're talking about dedicated a lot of time to peer support enhancement and evaluation. The next few slides are all about peers, but there's a variety of issues that are being dealt with. So the first is a report is going to be issued on the provision of peer support services under Medicaid. Right now, there are states that do reimburse peers under Medicaid, but it's really varied across the board. The states have vastly different reimbursement ideas for what the peers should be reimbursed for. We're trying to find what a common thread is. So the report will examine the mechanisms through which reimbursement can exist, the populations to which the states have provided peer support and coverage, payment models, including alternative payment models used by states to pay providers of peer services, and where available, information on federal state spending under Medicaid for peer support services. So we want a better sense of what exactly is going on, because what's going on in Massachusetts is not what's going on in California. What's going on in Arkansas is not what's going on in Oregon. And we want a better sense of that, so states that do want to enter into this area and have not yet can have a better idea of what best practices are and what can be reimbursed. There's enhancement and evaluation review, as I was just talking about. There will be recommendations for what is the best practice area for peer support services and how they can be best accessed as well. It's not enough to have the peers. We have to know that the population is aware of their capability to access them. Having all the peers in the state is going to help if access is not granted to them, to the population that really needs their services. To that end, there will also be the establishment of a national peer-run training and technical assistance center. This center will provide technical assistance and support to recovery community organizations and peer support networks, and will establish best practices for the delivery of recovery support services. Recovery is also making, peers in recovery are kind of go hand in hand. And this bill is not just about treatment. It's about recovery services as well, very large part of it. And policymakers on Capitol Hill are realizing treatment does not end, or the process does not end when someone walks out the door, whether it's inpatient or whether when someone is discharged from outpatient. This is something that as we have said, some people have given it the label of a chronic disease, and it's a lifelong effort. So making sure those resources are in place for people who need them is very important. Cuts down on I have to be careful about the words I use because there's quite a debate going on in the community about which words are appropriate. But we want to cut down on relapse, and we don't want a revolving door. We don't want people going through treatment numerous times when we can do it once, do it right, and make sure that they are living a healthy life without a need to come back. So that's why the role of the peer and the role of recovery is so important. This is something I found really interesting in terms of advancing that narrative. The Career Act, which was folded into HR6. It's going to improve resources and wraparound support for individuals in recovery from a substance use disorder who are transitioning from treatment to independent living. This will include the hiring of case managers, care coordinators, peers for recovery support, other professionals as appropriate, to provide services that support treatment recovery, rehabilitation, and prevent relapse and recidivism. Years ago at SAMHSA, there was a director, an administrator named Charlie Curry. Some of you may remember the name. And his motto for SAMHSA was "A life in the community for everyone." And what he was the narrative he was trying to advance with that was, it's not just about treatment, it's about a life in the community. And when someone's asked him that, he said, they asked, what does that mean, a life in the community for everyone? He said, a job, a home, and a date on Friday nights. That's what he envisioned. It's not enough to just fight the disease. All of these resources, a job, a home, a stable life, are necessary to make sure that we cut down on relapse and recidivism. So we are making a heavy investment in that. This is one of the first times, with the exception of the CARA legislation, that a federal law has really addressed the importance and the need for recovery services. There's also something called the POWER Act, which was folded into this, the Preventing Overdose While in Emergency Rooms. This is a program to support coordination and continuation for drug overdose patients. And this kind of goes to what the phraseology is: warm handoff. Someone comes into an emergency room having overdosed, and they're at a point where you may be able to get them into a treatment protocol. They are at a point where they may listen, they may feel vulnerable. This will work on that warm handoff from the emergency room to treatment. Now, whether that is inpatient, outpatient, MAT, cognitive therapy, that is for those who do the assessment to decide. But we want that assessment done. We want patients to acquiesce, and this will help in that process. There's also provisions for youth prevention and recovery. This could establish a resource center to provide technical support to recipients of grants, a program to provide support for communities to support prevention, treatment, and recovery of substance abuse. This is very community-based. A recovery program that includes peer-to-peer support delivered by individuals with lived experience and communal activities to build recovery skills. So again, we see the stress on community. And provided for this would be $15 million to replicate a recovery coach program for parents with children in foster care due to substance abuse. One of the largest economic impacts of this opioid epidemic is on the foster care system, especially in states like West Virginia and Kentucky. The amount of money, resources, everything that has gone to a very overworked and overloaded foster care system is staggering. And if given a chance to do a second webinar for C4, I could do a whole webinar on that subject, the economic impact of this. But this will seek to address helping those parents with children in foster care be as a result of their substance abuse. This is a really innovative program called B-Corps, Building Communities of Recovery. I always joke, I'm throwing all these acronyms at you, the Support Act, the Power Act, B-Corps. If there's ever a way to make a living just from making up acronyms, I want that job. It's quite a, requires quite a bit of innovation. But this B-Corps program would award grants to recovery communities. Recovery community organizations to enable the organizations to develop and enhance services. So we've already seen we're going to make a commitment to developing a peer workforce. We're going to make a commitment to develop best practices, and now a commitment to develop the communities. So the definition of recovery community organization, you can see there below. It would mobilize resources within and outside the recovery community, which would include, may include peer support networks to increase long-term recovery from substance use disorders. And it would be wholly or principally governed by people in recovery for substance use disorders. Allocated for this is $5 million. Now, you know, I mentioned before how we talk in Washington, you know, 3 million here, 5 million there. There's a very famous saying by Senator from Illinois, Everett Dirksen. He said, $1 billion here, $1 billion there. Soon you're talking about real money. Just on the Hill yesterday, I overheard a conversation where someone said, we're not asking for a lot here. It's only $500 million. Personally, once you add that third comma and get over 100 million, I tend to think you are talking about a lot of money, but 5 million is not a lot. So this is a very, very big effort we're trying to undertake. We're trying to establish this nationwide. 5 million, really not sufficient. So again, this is a work in progress, and as the appropriation and budget process comes around next spring, it's programs like this that we're going to say we need you know, we've got the language to establish it. That's one thing. Now we need the money to fund it. Pilot programs to help individuals in recovery from substance use disorders to become stably housed. Again, housing, as I mentioned before, very important part of recovery. This would provide assistance to states to provide individuals in recovery from substance use disorder temporary housing. It's good to know you have a place to come home to. It aids in stability, aids in job search, aids in nutrition. So it's a very, very important piece of the puzzle. It's not just what this bill does is, as you can see, it goes well beyond the clinical aspects of just treatment, and it gets into a more person-oriented considerations. I wanted to address the IMD exclusion. I know many of you know what this is. For those of you who don't, I can give a very brief description. Ever since 1964, through an interpretation of the Social Security Act, the Center for Medicare and Medicaid Services has limited any inpatient facility that accepts Medicaid funding to 16 beds. That includes a psychiatric hospital. That includes any inpatient substance use disorder treatment facility. And it was really, really, for lack of a better term, oppressive. And we've been working on fixes for quite some time. And what we got previous to this was quite a bit of waivers. States have been allowed to apply for waivers, a little nibbling away, a little gnawing at it, but we never really got rid of it outright. This bill doesn't quite get rid of it outright, but what it does is for the next 5 years, it states that the bed limit is lifted. So there is no federal restriction on the number of beds in an inpatient substance use treatment facility that accepts Medicaid funding. That does not mean your states cannot continue to impose limits. They can. Medicaid is managed by each state individually, even though the federal government has to sign off on different requirements, different reimbursement models. Each state gets to decide. So this means if a state wants to go beyond 16 beds, they are free to do it. The federal government will not stop them. However, it does not mean your state must go beyond 16 beds. Along with this, there will be a 30-day limit for inpatient treatment coverage by Medicaid over the course of 12 months. I know that is disappointing. That is not ideal. However, that was, I think before this was put in place, that was already there, and there were already provisions that allowed for back-to-back 30-day periods of treatment if necessary, if deemed necessary by the medical staff. So it's not like there's a new restriction. It's just that restriction was not lifted, but the bed limit restriction was lifted. So that's a pretty big win. The IMD exclusion was something that was really hamstringing us when it came to inpatient treatment. I think everybody knows that having one facility of 50 beds is far more efficient than having 3 facilities of 16 beds each. So that was part of this legislation as well. Okay. I want to kind of wrap this up and put a bow on HR6 and just talk about a few other things. And as I conclude, I want you to know this. I don't know what all of you out there know about this legislation before you tuned into this webinar. You may know a lot, you may know nothing. I hope you know more than when we started. But there was some criticism of this legislation. Some people thought it didn't do enough. To that I say, good is not the enemy of perfect. Those of us who worked on this legislation, we do not see it as a culmination. We see it as just another step. We are going to continue working on this issue. I will be honest though, more than half the bill focused on 2 aspects: overprescribing and Medicare Part B reimbursement as it pertains to substance abuse treatment services. The overprescribing issue is really a hot topic in Washington, and I'm very weary of it. I know that it has played a very, very large role in our opioid epidemic. I know overprescribing needs to be curbed. I will advocate for that. But I want you all to understand with me that you probably do. Overprescribing is not why we are in this mess. There was an opioid problem in this country long before the overprescribing started. It may have helped blow it up much faster, but it's not the reason. There are policymakers out there who think it is the reason. And anyone who thinks that we are only in this mess solely because of overprescribing does not understand the disease of addiction. Addiction has been around for millennia. It's been around in this country for centuries. And I honestly believe that so long as we focus solely on overprescribing, which a lot of this bill does, we will not make enough headway in fighting the disease of addiction. And that's where I'd like to continue as we move beyond HR6 for the last part of this webinar. People have asked me, so what's next? You know, what's next? We've done this bill on opioids. Well, first, we're not done with opioids. This bill will do a little bit. A few $1 billion, I'm sorry, when 70,000 people die of an overdose each year, and hundreds of thousands, if not millions of more, suffer from addiction, and only 10% of those people are getting treatment services that they need, we're not done. There's already talk of another bill being done now that the Democrats have control of the House and control of the committees that would have oversight over this legislation. That would be the Energy and Commerce Committee. There's already talk that the Democrats are working on a second bill, and they want to address all the things that weren't addressed in the first one. Treatment infrastructure. Again, more workforce, better recruitment and retention, higher availability of medication-assisted treatment. Whatever the case may be, whatever the priorities of the Democrats are, they felt this bill did not do enough. And so they're already getting to work on it. In addition to that, as I started this webinar, I said, this country doesn't have an opioid problem. This country has an addiction problem. And you see that in the news more and more. I am seeing reports, and I follow the data very closely. I am seeing reports of methamphetamine being, quote, back. I saw a headline the other day. I probably should have included it, although, as I said earlier, I try to cut down on my visual content. There was a report that said methamphetamine is, quote, back. Methamphetamine is not back. It never went anywhere. The areas of this country that were inflicted by impacted by a horrible methamphetamine scourge in the later part of last decade, it's still there. I represent people all over this country, and they keep telling me we're still dealing with methamphetamine. It has not gone anywhere. There's also a rise in cocaine abuse. There's, as we know, a rise in the amount of fentanyl being added to cocaine and to heroin, and the number of people who are seeking out fentanyl as their drug of choice. And now that we seem to have addressed opioids, the marijuana issue is back as more and more states are putting recreational marijuana on the ballots, which comes with a variety of other complications. Again, I could do a whole nother webinar on marijuana policy, but I'm coming to the end of this webinar, but there is still plenty left to do, and outside the world of opioids. And I'll say it's not even listed there, but you all know what the answer is. What is the most abused substance that causes the most damage in this country, whether it comes to court costs, property damage, lost productivity in the workplace? It's alcohol, and we all know it. And until we address alcoholism as the disease that it is, we still have our work cut out for us in Washington. There's still plenty of work to do on the policy front when it comes to treating addiction and advocating for recovery services in this country. So I've looked at my clock, and I see that we're coming up on 1:45, which is right about where I want to be. I want to leave time for questions. If you don't have any, that's fine. But if you do, I'd like to answer them. You have my Twitter handle. And if you wake up in the middle of the night tonight and say, ooh, that was a question I would have liked to ask, feel free to put it on my Twitter feed, or however else you think is best to phrase your question, and you go right ahead and do that. So if there's any questions, about the presentation I've just done, and about all of the information I've just presented to you, I'll be happy to take those questions now. I see there's a question. Okay, we have a question about prevention. Do any of these bills act and address this? There is a little. I would be the first to agree with you that there's not enough. When it comes to prevention, the first place I want to go is obviously to funding. Right now, the Substance Abuse Mental Health Services Administration is required to give a block grant to each state, and 20% of that grant is set aside prevention. It's what we call the prevention set aside. I believe in 13 or 14 states, that set aside, which is a few $1,000,000 at best, is 100% of their prevention funding. Based on the latest statistics I have, that set aside accounts for 50% of more of prevention funding in 38 states. And that is not good enough. And I agree that we need to do more on prevention, and there wasn't enough. Part of the problem when it comes to how prevention is defined in this legislation is that for years, money that went to naloxone distribution, or naltrexone, the overdose reversal drug, money that went to that was considered prevention. Now, those are my friends of mine, I myself and colleagues of mine, one of the associations I work with very closely on prevention is CADCA, Community Anti-Drug Coalitions of America. Many of you probably heard of them, and they do great work, and I tend to follow their lead on prevention. Naloxone and overdose reversal, that's not prevention, but they were counting it as prevention dollars. So some people will say, yeah, see, we've got prevention, it's naloxone. No. That's like saying a defibrillator is practicing good heart health. No, eating healthy and exercise is good heart health. A defibrillator just gives you a second chance, which is what naloxone does. There is one area of prevention that is cause for optimism. The Office of National Drug Control Policy was reauthorized there. I'm speaking DC, but the Office of National Drug Control Policy is responsible for administering the many grants, the drug-free community grants across the country. And under the current administration, there was a lot of concern that the Office of National Drug Control Policy could be downsized. What this legislation did was it reauthorized or reestablished those programs. So the best thing I can say about prevention in this bill is that we kind of staved off we prevented a very good program from being eliminated. So we kind of, unfortunately, had to view that as a win. So the drug-free community grants were reauthorized. Those will continue to go out from the Office of National Drug Control Policy. But as far as new programs are concerned, I'm sorry to say it, we did not see enough. So we're going to continue to work on that in the future. Okay, I have a question. Will these slides be available, sent out to webinar viewers? Yes, they will. C4 is going to, I'm not the technical guru behind all this, but C4 Recovery is going to assure that the slides and this presentation is available and archived, and they will be available. Yes, absolutely. I don't see any more questions at this time. I am happy to stay a little bit. I just want to remind everybody that once we sign off and we're finished, there's going to be a poll. It's only some brief questions, 5 brief questions at most. And C4 would very much appreciate your feedback. So not seeing any more questions and knowing that there's only a few more minutes left in the hour, I'm going to wrap up. I'm going to thank you all for your attention. I know this is a very, very complex issue. I do. I've just tried to sum up 700 pages in an hour. And I talk fast, and there was a lot of information. But the goal of all of this was just to give you an idea of what's going to be coming out of Washington over the course of the next year. All of these programs that I mentioned, all of these grants, all of these opportunities for feedback, they're going to be trickling out. So stay in touch with your single state agencies. Stay in touch with people who know what's going on at the state level, because now as they receive this information and you receive this information, at least you'll have a foundation to know what it is we're talking about. And you'll say, oh, I remember that, I heard of that. So there's going to be opportunities for involvement. There's going to be opportunities for grants. And most of them are aimed at treatment and recovery. And I think the people attending this webinar would be real interested to see what comes of it, and be interested to give their feedback to their members of Congress and the Senate. So with that, I thank you, and I want to wish you all the best holiday season. Enjoy the holidays and the new year with your friends, family, and colleagues. Try to get some rest. Try to have a peaceful holiday and new year. I wish you all the best, and I look forward to speaking to all of you whenever the opportunities present themselves in 2019 and beyond. So thank you very much.